First of all these geriatric evaluations, they are very critical to the better treatment of our older cancer patients. But unfortunately, the education of oncologists in Brazil do not, until this moment, do not place strong emphasis on the particularities of these patients. So there is a lot of work to be done in the process of education of new oncologists. This is one thing, and so that the majority of them will understand the need for these evaluations, and because it is still widespread that clinical examination can by itself detect some fragilities of older cancer patients, which is not the case. We need more refined tools to this detection. And besides of the education issues, there is always this idea that these evaluations, they take a lot of time, human resources, and so there is a need to, while at the same time maintaining efficacy of these evaluations, they should be somehow simplified so that these evaluations, these critical evaluations, can be more of widespread use and to the benefit of as more patients as possible. The aim of this pragmatic geriatric assessment, it was an idea that it came up. It's a bit strange, but it came up from it's an idea of design of from Scandinavian design, that very nice things, very functional things, very beautiful things, pieces of design. They should be everyone can afford them and can benefit from them. Yes, and when you look at Scandinavian design, they are all these pieces of design. They are functional. Yes, they are simple, and they are beautiful. They are cool. Let's put it like this. So I tried to in our center on Cosinos, we tried to create a tool that could be very efficient. And in this, we had also this idea of the Pareto principle, that most of the consequences, yes, comes from very little of cause. So if we could go to the core of the problem, yes, we could achieve much more pieces of information. So we wanted a tool that could be efficient, functional, simple, and that it could be easy to use. That was the main idea. That it was to simplify and to make the possibility of these geriatric assessments to be more used widespread in the world. The first thing that what it's very important is that we evaluated 71 patients in our institute from age 60 to older, but the majority of them had more than 65 years old, and all kinds of tumors were evaluated, and the median age was 73 years old. Yes, so it was quite an older population. And what is very interesting is that the time to perform these evaluations, all these evaluations was the median 9.5 minutes, less than 10 minutes. And what we found was that we evaluated basically a measure of vitality, of a measure of functional reserve, which is gait speed, yes, and with a threshold of 1 meter per second. And in this regard, we found that 40% of patients were pre-fragile, and about 20% of patients were fragile. So only 40% of our population was what we can call fit or non-fragile, which fits very well with the most widespread screening evaluation used in Europe and the US, which is the G8 score. So we used the gait speed as a pre-screening evaluation, like the G8. That was the main idea. And so with this, we can already note that 60% of our population is pre-fragile or fragile. And so with difference with the G8 score, yes, the G8 score, it takes about 4 or 5 minutes. That's okay, but it's a screening test. And so we thought that we substitute the G8 for the gait speed. We have a wonderful paper by Frédéric Pamodcham from the Department of Geriatric Oncology in Bobigny, France, from 2017, who showed that the gait speed correlates quite well with in sensitivity and even better specificity than the G8. So we ask the patient to walk. It takes 1 minute. We have the gait speed. And instead of sending or not the patient to geriatric evaluation, we are already in front of the patient. Why not to take this opportunity? Yes. And so we decided to evaluate the 4 more domains, which is nutrition, with a mini nutritional evaluation, polypharmacy, which is a widespread problem in the older geriatric population. Yes, you can adjust treatment and take out some medications which are not needed. And risk of depression, which is also about 25% of patients worldwide, cancer patients have depression. So we can detect it very fast with 5 small questions. It's a geriatric depression scale 5. And on the end, we added a cognition evaluation by the mini-cog exam, which takes 3 minutes. So we evaluated nutrition, polypharmacy, risk of depression, and cognition. Yes. So what we found, and nowadays we do this in a median of less than 10 minutes in general. And so what we found in our analysis of 71 patients in resume, we found that the median time to perform our pragmatic geriatric evaluation was 9.5 minutes. It varies from 5 minutes to 16, but in median 9.5. 40% of our patients were pre-fragile, 20% patients fragile. We have 51% of patients taking more than 3 medications, so we can adjust. For instance, some patients take 2 kinds of benzodiazepines. You can take 1, of course. Risk of nutritional risk, 60% of the patients. Risk of depression, 25%. And the cognitive risk, 40% of patients. So in general, we found in these 71 patients, we found 126 instances where you can make medical interventions before the treatment as a kind of prehabilitation and not to rehabilitate. You prehabilitate the patient to the treatment, you adjust the treatment with these pieces of information. So in 71 patients, we found a very fast, very efficient 126 instances where we could intervene medically. You know, that's a very good question. There are already some centers in Brazil which are planning to use our pragmatic geriatric evaluations, which one of them, the north of Brazil, which is called ProNutri, is the biggest oncology center in Fortaleza, in a state called Ceará. And we are working with, of course, the work continues in Oncocinos and also in the Fevale University. And you know, it will come. Your interview in ecancer will help a lot to disseminate this message. And this pragmatic geriatric evaluation is I think it's very important, not only to developing countries, but even to more developed countries, because it is can be performed very fast, gives lots of pieces of information, and it can be used. It can be done very simply by, for instance, a trained nurse. Yes, and we created. In the meantime, we created a website called oncosenior.com, in which these tests, they are already available, open source, to all physicians, to all medical students, to all medical wards. Physiotherapists, for instance, also can perform these tests, so that it can be available and widespread to as much people as possible, to enhance the treatment, for better treatment of senior cancer patients, for older cancer patients. So that's how we are working on this aspect. And it is already in Portuguese, in English, and French. And soon it will be German, Spanish, and Russian also. So that hopefully a patient in India or in Moscow or I don't know, south of France, they can also benefit from this tool. Yes, there is something I would like to add. That besides the benefit for the patients themselves, which is very clear, there is also the possibility. There is also the potential that this tool it can help with the economy of millions of dollars each year in the world, because the use of these tools gives the physician pieces of information that will allow him or her to better design the treatment of the particular patient. Yes, so this means